The CAD3 study design is a prospective, multi-center, single-arm global IDE study performed in 4 countries, the US, UK, Germany, and France. Patients with heavily calcified de novo coronary lesions were enrolled. This definition includes radioopacities on both sides of the vessel extending at least 15 millimeters in length by angiography, or a calcium angle at least 270 degrees by intravascular imaging. The primary endpoint was assessed at 30 days, and there was a 100-patient OCT substudy. The primary safety endpoint was freedom from MACE at 30 days, and MACE was defined as cardiac death, myocardial infarction, or target vessel revascularization. The primary effectiveness endpoint was procedural success, defined as successful stent delivery with residual stenosis of less than 50% without in-hospital MACE. Key secondary endpoints are shown and include procedural success with a residual stenosis less than or equal to 30% and no in-hospital MACE to allow a sensitivity analysis with a more contemporary definition. These are the baseline clinical characteristics. The average age was 71. 90% of patients had either hypertension or hyperlipidemia, 40% had diabetes, and 26% were defined as renal insufficiency using an eGFR of less than 60. As you can see on the right, 70% of patients had class 2 or 3 angina. These were the baseline angiographic characteristics, including a baseline reference vessel diameter average of 3 millimeters, lesion length average of 26 millimeters, and a calcified segment length of 48 millimeters. 100% of these target lesions were classified as severe calcification. These were the procedural characteristics, which show that 50% of the targets were predilated with a 2 millimeter or less balloon. An average of 69 IVL pulses were administered per case with a maximum IVL balloon inflation pressure of 6 atmospheres. Over 99% of stents were successfully delivered. These are the angiographic outcomes on the left. You can see the stepwise reduction in severity stenosis from pre-procedure to post-IVL and final in-stent. And on the right, the stepwise increase in minimum lumen diameter at the same time intervals. A diameter stenosis of less than 30% was achieved in 99.5% of patients. These are the angiographic complications noted as post-IVL and final. As you can see, severe dissection type D through F was observed in 2.1% post-IVL. This was reduced to 0.3% following stent deployment at the end of the procedure. Note that perforation, abrupt closure, and no reflow were 0 post-IVL. These figures at the end of the procedure were 0.3%, 0.3%, and remained 0 for no reflow. The primary safety endpoint, freedom from 30-day MACE, was observed in 92.2%. The lower confidence boundary of 89.9% meets the safety performance goal. The primary effectiveness endpoint, stent delivery with residual stenosis less than 50% and no in-hospital MACE, was observed in 92.4%. Again, the lower confidence boundary of 90.2% meets the effectiveness performance goal. This slide shows the in-hospital and 30-day MACE of 7 and 7.8% respectively, along with the individual components. Key secondary endpoints included device crossing success, angiographic success with a less than 50% residual stenosis, angiographic success with a less than or equal to 30% residual stenosis. All of these were 96% or greater. Procedural success with residual stenosis less than or equal to 30% was 92.2%. IVL ventricular capture has been noted before this study, and in this study demonstrates that 41% of patients had some evidence of IVL-induced capture. It was significantly more common if the pre-procedure heart rate was lower, particularly by multivariate analysis less than 60 beats per minute. The drop in systolic blood pressure was more frequent, but as you can see, not more severe based on this analysis. And there were no significant sequelae. In conclusion, I'd say that the success of the Disrupt CAD3 trial was achieved, as both the primary safety and effectiveness endpoints were met following treatment with coronary IVL in severely calcified lesions. Coronary IVL prior to drug-eluting stent implantation was well tolerated, with low rates of major periprocedural clinical and angiographic complications. Transient IVL-induced ventricular capture was common, but was benign, with no clinical sequelae in any patient. And although this study represents the initial coronary IVL experience for US operators, high procedural success and low angiographic complications were achieved, reflecting the relative ease of use of IVL technology.
I'm Margaret McIntyre, a consultant cardiologist at the Golden Jubilee Hospital in Glasgow, and I'm now going to talk to you about the Disrupt CAD3 OCT substudy. From Disrupt CAD 1 and 2 OCT substudies, we know that IVL can induce multiple circumferential calcium fractures, and ultimately in all these cases resulted in good stent expansion and stent outcomes. The objective of the OCT substudy in Disrupt CAD3 was to further elucidate the action of IVL in these de novo heavily calcified coronary lesions. What was unique about the study was that OCT was performed at baseline, following IVL and following stent expansion and delivery. In the overall study population, there was 431 patients, including the roll-in population, 1 patient in each site. Within that population and the intention to treat population, 100 of these patients were included in the OCT substudy, and that's the data that we're going to look at now. So looking at the baseline characteristics, the 2 things to note, as you might anticipate, is that the OCT patients were less likely to have renal insufficiency. They were also less likely to have had prior bypass surgery. If we look at the angiographic characteristics, you were more likely to have OCT if it was an LED lesion that was being treated, and less likely if it was a circumflex lesion. You can see that the reference vessel diameter, minimal luminal diameter, were both slightly larger in the OCT group, whereas the diameter of stenosis was slightly smaller. Now, the absolute values that were different between the 2 groups were very small and probably irrelevant. Looking at the procedural characteristics, of particular note is that the OCT patients actually had shorter procedures at 58 minutes, although this was not significant. This is obviously very interesting in the context of imaging and physiology often being associated with leading to longer procedure times, which wasn't the case here, allowing you to perform precision PCI in a timely manner. What you can see is that if you used OCT, you were likely to use slightly more pulses of therapy, and you were less likely to use predilatation, presumably because being able to cross a lesion with the OCT catheter gave you confidence that the IVL balloon was going to cross without any pre-treatment. So looking at the serial OCT measurements from pre-IVL, post-IVL and post-stenting, you can see the MLA gradually steps up, as does the improvement in the diameter of the area of stenosis. You can see that the maximum calcium angle was 293 with a thickness of almost 1 millimeter. And you can see that the mean stent expansion was over 100%, which is excellent. This is a graphical representation of this stepwise shift in the luminal area gain. So you see pre-procedure, post-IVL, we get a step up in gain and then a further step up in gain after stent deployment. 67% of the lesions had a fracture that was visible in the OCT, with a minimal angle at the fracture site of 192 degrees, which is consistent and in keeping with the recommendation to use a device for angles of calcium over 180 degrees. You can see from the graph on the right-hand side that following stenting, there was a significant increase in actually the width of the fracture. Interestingly, there were obviously a reasonable proportion of patients where there was no visible fracture seen in the OCT. So they went on to analyse visible fracture versus non-visible fracture, and what they saw that was in these 2 populations of patients, there was no ultimate difference in the MSA, stent expansion, or the final area of stenosis, whether a fracture could or could not be seen in the OCT. And the thinking is that this is most likely due to the presence of microfractures that the OCT can't detect. And this is some data from the femoral artery where they use micro-CT and histological samples, which shows this phenomenon of these microfractures that you can't pick up with the resolution of OCT. And the suspicion is that this is the same mechanism in the coronary artery, with an intention to go on and perform cellular analysis to confirm this. Looking at safety outcomes and performance outcomes, the device crossing success was 100%, procedural success 98%. You can see the angiographic measured outcomes are very good down in the left-hand corner. Looking at complications, there was no complications in the OCT cohort within the study. So in conclusion, OCT confirmed the safety of coronary IVL with no severe angiographic complications at the end of the procedure. It demonstrated both longitudinal and circumferential calcium fractures in these heavily calcified lesions, resulting in increased vessel compliance, large post-procedural MSA, and excellent stent resultant expansions. The MSA, area stenosis, and stent expansion outcomes were excellent regardless of whether a calcium fracture was visible in the OCT, with the current assumption that this is due to subtle microfractures or fractures out of plane that are non-visible on the OCT.
So welcome everybody to CAD3 Shock Talk. We're going to be talking about how IVL is impacting calcium treatment in the UK. I'm really delighted to be part of this symposium, joined by friends and colleagues. It's a great pleasure to be able to introduce Professor Andreas Baumbach from the Barts Heart Centre in London, Margaret McIntaggart from the Golden Jubilee in Glasgow, and Ian Webb from my old stamping ground at King's College Hospital in London. We've got a lot to discuss. We've got a very interesting set of data that has been published recently with the CAD3 study. It was really built on the Disrupt CAD1 and CAD2 studies. So very exciting times ahead. I think the UK has probably been one of the leading centres from the outset. It was only just about 3 years ago today that the first Shockwave live case was done from Margaret Centre with a fantastic demonstration of this technology. I think at that point, most of the UK interventional community was convinced that this technology had legs, and I think here we are 3 years later. So I'm going to come to Andreas first, and specifically talking about the CAD3 data. What do you think the CAD3 data now offers to the UK physicians who've been using IVL like you for some time now?
Thanks, Jono, and thanks, Jono. And as we've seen in your presentation, this really builds on CAD1 and CAD2. And for us in the UK, it just shows what we have seen in practice over the 2-3 years that we've been exposed to the technology already. The main message, I think, is that this technology is safe. So I think my message from CAD3 would be that this device has proven its safety profile.
Margaret, Ian, do you have any comments about the way your practice might change, or whether this adds to your current practice with CAD3 publication?
I think that always seeing published data, I think, is always reassuring when you've adopted a technology into your everyday practice. So for me, it provides me with great reassurance that to continue to expand my use of the device in everyday practice is appropriate and a safe way to treat the patients.
Yeah, and I would echo that. I think the technique is rolling out very quickly. I think users throughout the nation, and broader in the international community, can see how effective this is. It's been demonstrated time again, and so having that published data really just to build on the safety aspect as well as the efficacy of good good stent practice, I think is very encouraging.
So Margaret, I'm going to ask you about calcium burden. And so since CAD3, they've sought to enroll patients with 270 degrees or more of calcium. So what do we know about IVL's efficacy, both in concentric lesions, which we accept is perhaps its real strong point, but what about its efficacy in eccentric lesions?
So I think this is really interesting, and I think that the management of eccentric calcium really is our kind of residual problem in calcium management. I think that there's always been this debate about 180, 270, 120. Where is the arc enough to need modification, be it IVL or be it anything else? So I'd say there's absolutely no doubt, looking at the data we have to date, that the efficacy in concentric is there. I think the real world experience, we all have experience of this, of using the device in eccentric calcium, where I think anecdotally, from an experiential point of view, we all feel that it has efficacy. But I think that data is coming. So I suppose we have to just continue to accrue that data to be able to definitively say that the device can work in that situation. I think it's important we differentiate between nodular and non-nodular eccentric calcium. And I think nodular calcium, traditionally we felt atherectomy is the best solution in that situation. Whereas non-nodular is a completely different thing. So I think possibly in the realms of non-nodular eccentric calcium, we'll see a kind of expanded use for the device.
Can I just ask Ian, are you now a universal user of intravascular imaging when you're using Shockwave?
Yes, well, I mean, just to move on from what Margaret was saying, I think with this concept of eccentric and concentric, this is where intravascular imaging really does help with that. And my own personal experience, I'm still not. I don't know yet whether the degree of eccentric calcium, whether Shockwave, the delivery of shocks, whether we perhaps have to use more up to 80 pulses. Rather than less in more concentric lesions where you have good apposition of the balloon. I don't know. That's part of my learning curve ongoing at the moment. But I think in terms of imaging within the coronary artery, I would certainly, if you're planning to use Shockwave up front, I think imaging is extremely useful.
Yeah. I think my experience has been with the eccentric lesions that, yes, they do respond, but I tend to use up all the shocks in the balloon. So remember, there's 80 shocks per balloon, and I will distribute those shocks along the whole length of the lesion, whether there's concentric or eccentric calcification.
Well, I don't know what the rest of the panel are fine, but I think with eccentric disease, you risk lulling yourself into this false sense of security where you have balloon expansion, which you're pretty happy with, and particularly if you don't post-dilate after the IVL therapy, where you think, right, I'm in a good position now. But then when you deploy your stent, you actually realize that eccentric nature has left you with quite a significant MLA impingement. Yeah. And I think, going back to Margaret's point, I think imaging and understanding the eccentric nature and quantifying that up front really will help you, because this is all about lesion preparation. And if you understand that it's going to be more difficult, then you can spend more time optimizing that. Mm-hmm.
So Ian, and coming to you regarding some of the safety aspects of CAD3, there was a sub-study that was mandated by the FDA about the electrophysiological effects. But what were your takeaways on the shock topics, these IVL-induced capture? What about the occurrence in CAD3? Was it consistent with your own experience?
Yeah, so I guess for those not familiar with what shock topics are, it's essentially ventricular extrasystole, which are induced by the sonic pulse wave. And traditionally, we think about electromechanical coupling. This is actually mechanical electrical coupling. So it's the pulse wave which then stretches the adjacent cardiomyocyte. So this phenomenon is very common. And in day-to-day practice, it's something you'll see. It's a 50-50 chance that you see it. It's one of those things that the physiologist will point out, and it's a point of interest rather than any clinical sequelae, and that's actually been seen in the CAD3 study as well. So broadly speaking, the study has shown that the incidence of shock topics is, I think, around 40% or so, and there's a transient and a rather minor drop in blood pressure during that time. Of course, you're delivering 10 energies within a delivery of energy. So the clinical consequences of this are not thought to be of any concern, and in real world data, again, likewise, it seems to be very safe and effective. I think for, strategically, we worry about RONT phenomenon. There are some anecdotal case reports of ventricular arrhythmia as a result of that, but again, the published data coming through, it seems to be a very safe technique. And indeed, in the data looking at those patients with pacemakers or ICDs in, likewise, that outcome and that data, that safety profile seems to be secure.
Sticking with you, Andreas, I mean, when this was introduced in your lab, do you think there is, is there any learning curve with use of the technology? Is it absolutely intuitive to use, or?
Well, I would say there is two learning curves, right? We've just heard you guys, you experts and frequent users talk about the second learning curve, the sophistication, adjusting what you do to what you see on OCT. The first learning curve, the handling of this device, in my eyes, is a caseload of one, maybe. It's a balloon with an oomph. It's you have to handle a balloon, and then you have to know which button to press, and then you have to, of course, understand what you're doing. But the handling itself does not require a learning curve. It's a balloon.
It's really important that, because it massively expands accessibility of calcium treatment to our colleagues who are not confident or you have high enough volume to be using atherectomy and other devices. And certainly in our group, as Andreas says, N of 1. So I've had several occasions that I've gone in and done one case with some of the lower volume operators, and then they've gone on to use the device, in the middle of the night in a difficult situation with confidence. So I think from that point of view, it's a real game changer.
But there's this one situation in the lab, however, where I think we should make note of that. This undilatable lesion that you come across maybe in the middle of the night, or just unexpected. You just don't expect that you cannot do the case. And it takes an N of 1 to convince you that this technology is, as you say, a game changer. Was it for me, the live case at ACI? Was it for the nation, maybe? You can do a case that you couldn't do before, and you can't prove that in a trial, but it's proof enough for you to actually really think this is a game-changing technology.
What we need to take now from CAD3 is the integration into the real world. So coming on to the practicalities then of how we're going to be using IVL, I want to come to Margaret and just ask about the economics. I think there's been a looking at the cost of the procedures. You did some comparison with rotational atherectomy. Can you just share what you found in those studies?
Yeah, so when we first got access to the device, internally we had to justify the economics, obviously, of a new technology. So the first 30 kind of cases in our learning curve, we did a cost analysis and then compared it to 100 rota cases. And at that first part of our learning curve, we found there was no significant cost differential in the cases. Obviously, quite relatively small number, 100 versus 30, and right at the beginning of our use. So it's interesting because preparing to discuss this today, it's got me thinking that we should now redo that actually. Because obviously, once you've learned about the technology and how to use it, I suspect that would be more favourable now. I think with the realising you don't necessarily have to pre-delete, post-delete, all these things that you would that I would have done before, when I was still in the learning curve of believing, I suppose, in the technology and how it would work in the vessels. So even at the beginning of the learning curve, no significant cost differential between the patient groups.
Well, maybe that's our responsibility now, to do that as for the BSIS community, the interventional community in the UK, is that part of the agreement that we had with NICE was that we would be collecting data, and we're contributing this to the all these cases are going into the CCAT database. So I think perhaps this is the time now. Maybe that's something that BSIS as a group would like to take on, and I'm sure you'd have lots of people contributing to that type of study. And Andreas, could I ask from if you put your sort of European hat on and your sort of role within EAPCI and European intervention, do you see that the environment for calcium modification in the UK is it the same within Europe? I mean, are we talking about the same patients, of course, but do you think that there is a different uptake of alternative technologies, shall we say?
No, I think we can say there's an abundance of calcium across Europe, and there is enthusiasm everywhere. So I think we're all facing the same problems. We're treating more elderly patients. We see more of it, and these tools are welcome because they are necessary to treat the whole spectrum of patients that we want to treat, and that is true here as it is in Europe.
I think come to you now, Ian. In CAD3, I think it was a slightly artificial situation. It wasn't really representative of our real world practice because concomitant atherectomy was prohibited, which is obviously not how it's going to be used in everyday UK practice. So what are the criteria that you currently use? What algorithm do you apply when you're saying you're going to use IVL alone, or when you're going to use it in conjunction with other devices?
So I think having the capacity to do both is important, and I don't think that'll leave us as exciting as this new technology is. Broadly speaking, for most calcium modification, I would reach for IVL first. I think it's as I said, a low velocity, safe way of delivering calcium modulation both to the intimal and media. It's a very attractive, elegant, safe model. The times where the situations where it's perhaps more difficult is where you have extremely stenotic lesions, where you may have problems delivering the catheter, and where you really want to achieve some initial headway with rotational atherectomy in order to get to deliver your balloon. And again, coming back to what we're learning through IVL and our capacity to use this in the best way, I don't know if that's actually the best strategy, and whether or not we should perhaps be using smaller IVL balloons before moving on to the correct 1-to-1 ratio balloons. I honestly don't know, but I think where you have extremely long segments of very disease segments, 95, 98, 99% disease, rotational atherectomy for me still has an important role before considering IVL therapy as a second stage. So,
Andreas, perhaps I could just come to you to give a final word about what would be your strategy for the use of IVL for calcified coronary disease. What would be your message to the UK interventional group, to this BSIS audience, about how we should be using IVL and how we should integrate it into our everyday practice?
Well, thanks for giving me that role to give a message to our colleagues here. I think first of all, we should all hopefully be put in a position that we can use it more, have less restrictions because of budgetary considerations. I think it's a technology that you really, if you don't have it on the shelf, you should have for that situation in the middle of the night that we have spoken about. I think it's an essential tool to bail you out. And then, of course, the further use in a more routine scenario, or even a routine use of it in whenever you see calcium, I think that is something for the future where we have to have much better trial data. What we can say for now, I think, having seen the presentation of the CAT3 data, is it is safe. Put aside the safety concerns, and it is safe to use.
Thank you. So thank you to all of you, to Margaret, to Ian and Andreas, and thanks to all of you for listening and attending this symposium. I think as a UK community, the BSIS community, we should actually be proud of the work that's been done by the UK interventional groups over the last few years. We've played an instrumental role in the introduction of the technology with the CAD1 study, the CAD2 study, and now with CAD3. I think we've got a very, we've had a great response from the regulatory agencies, from NICE. We were instrumental in gaining the CE mark, and I think more recently with FDA approval. So I think we should continue to do good work with Shockwave, and thank you to all of you for listening.